Dr. Khaldun Algerian is a clinical professor of pathology at the University of Alberta, Faculty of Medicine and Dentistry, and an adjunct professor with the John Doster Health Ethics Center. He specializes in autopsy, and it has paved the pathway for his interest in health ethics, including his Master of Ethics at the Joint Center of Bioethics, University of Toronto. Without further ado, I pass you on to Dr. Algerian. Thank you for being here.
Thank you for this beautiful introduction. I just wanted to say to everyone, happy Halloween. Hope you enjoy my costume and enjoy your Halloween and you stay safe. Today, I'll talk about obstacles that are faced by the dead that we see in our everyday clinical healthcare work. I titled this talk as the cemetery fence and obstacles to healthcare faced by the dead. And we chose Halloween to be the presentation day. So our objectives today include that at the end of the presentation, we will recognize autopsy as healthcare as a healthcare option at the or during the end of life discussions and as a final consultation. Also, we'll be familiar with obstacles faced by the dead as a vulnerable group and so-called cemetery fence. At the end of the presentation, we will also be familiar with possible champions to these obstacles. Our first objective is the service or the procedure of autopsy as a healthcare option at end-of-life discussions. So what is an autopsy and why do we call it the final consultation? The autopsy is an examination that is invasive to the dead body to discover the cause of death or the extent of disease and or the therapy used prior to death, and to issue an autopsy report to the family and the requesting physician and family physician. It is the final consultation because this is the last time we are able to provide any medical or healthcare services to this human being. We often say in pathology that death delights to help the living. The reason why we say this is because the information gained from the autopsy helps maintaining quality of patient care, develop, modify efficacy of treatments. It helps teaching our medical students, non-pathology residents, and future pathologists. And it helps with the medical causes of death on the death certificate and makes the vital statistics more accurate. I'd like to share this painting where the painter shows truth at the bottom of a well, hidden to all. I like to view this as prior to autopsy, some information might not be available to us. And then the painter also shows a mirror in the well. Once truth has held the mirror and is able to shine the light onto herself, then truth can slightly be seen. And that is an example, or that can reminds me of the mirror used in earlier microscopes, where we reflected light as a light source to see our H&E slides and show the diagnosis or the truth. And then the autopsy report emerges from the well, or the truth emerges from the well, and the all pathological diagnoses are revealed. The next objective are obstacles faced by the dead, and as I describe them as the vulnerable group of vulnerable groups, and hence the cemetery fence. And so, like a cemetery fence as an obstacle, the dead will also have obstacles in receiving this type of procedure. What are these obstacles? What are the cemetery fences preventing this procedure if it is so beneficial? First of all, the previous person is now a human, is dead, and therefore cannot speak. And regardless what vulnerable group they were before life, now they are even more vulnerable. The second is death itself and the feelings surrounding that, whether they are traditions, cultures, religions, or other opinions on death is always a difficult time and a difficult situation. Another thing that we also like to talk about in hospital or clinical autopsy is that this is a requested autopsy. This autopsy requires informed consent by the next of kin. And what it is confused with many times are medical examiner or forensic cases or coroner cases where this is required by law, such as in Alberta, where we have the Fatalities Act, and those cases are required by law, and the authorization for these autopsies are achieved through the Fatalities Act. Informed consent as a process is difficult because we're dealing with dead, and we're dealing with death in the time with the next of kin in the time of the death of a loved one. Additionally, the informed consent may not, as I said, is required and is a legal document. And to many healthcare workers, this legal document is a complex legal form that we are not trained or understand the terminology which is on these forms, that can be confusing to both sometimes the pathologist, but also to the physician that is required in let's say even in the middle of the night to take consent from family members. And so we're accustomed to more healthcare terms that we commonly use and not to the legal jargon. Also budget constraints, because the healthcare system has to find a way to pay for it. And in Alberta, it is AHS makes this available to all residents of Alberta. And so it is free of charge with regard to the procedure itself. Additionally, another obstacle is alteration in medical education from a course based on scientific projects, scientific subjects, to a family medicine approach, which is, or a case study approach based on, let's say, becoming a family physician. And so many subjects within the laboratory have a Class B or Class C level of importance with the restricted time of the schedule of the medical student, and many courses become of less significance. And many times the presentation is not given on autopsy, or if it is given many times, it will have misinformation or alternate facts, which the lecturer may think is correct, but is incorrect. And so some of that information that is offered at these at some of the medical schools will be either misinterpreted or presented in an incorrect way, giving rise to generations of misinformed medical students. And then the timing of the consent is very difficult, because not only are you dealing with death and dying, but you're also maybe a junior physician, and this may be the middle of the night on a weekend, and you may not have ever seen this legal form before. Makes it even more difficult. Our last objective is, are we familiar with how to go forward? And so what are the solutions, instead of do we only have obstacles? So what are the solutions, and what are our possible champions to these obstacles? So the way I see it now is that we as pathologists, non-pathology healthcare professionals, and the public are not cooperating properly with regard benefiting from the postmortem examination or the autopsy. And therefore, we are not able to advance with regard the autopsy. This being Halloween, and also previously, or maybe currently, celebrated from my reading, Soin is how I believe that it is pronunciated, is a Irish festival or Gaelic festival that starts at the end of harvest, or in the evening of the 31st of October. And in this famous story, the burner, or Aillen, maybe is how it's pronounced, would attack the village with these rays of fire. And however, from this band of people, an Irishman by an anglicized name, McCool, would come and save the village from this, I guess, Halloween monster, if you may. And so that is that champion. And so we are looking and trying to discuss and brainstorm solutions to resurrect the autopsy. Many times, pathologists will see themselves as invisibiologists, and so they feel, or we feel, that we are behind the curtain. We feel that we are, as in this case, in our case at the University of Alberta, in the basement with no reception, and we are not able to voice our concerns many times. And this is a painting of that idea of the pathologist feeling that they are away from decision making with regard the medical education curriculum for medical school, or decisions with regard what is part of quality, what is not part of mortality and morbidity rounds. So the inability to express through providing information from the autopsy for quality care, or for mortality and morbidity rounds, or at the medical school level. And so what is our path forward, and how do we deal with this? So our path as pathologists should be in specializing in autopsy. So the ones that are interested or have a fellowship in autopsy should be the ones performing these autopsies, as opposed to a general pool of pathologists, many of whom are specialized in other organs or in other diseases. And in a way, that specialization also helps the turnaround time, and which also the satisfaction of the requester or the ordering physician on the clinical side. So the timing of the report always plays a role, but with specialization, that turnaround time is usually solved. The other thing would be that physicians, if they are able to see the autopsy as a quality improvement and a tool for morbidity and mortality, and for quality improvement, whether it's for diagnostic tests, so to compare with chemistry, to compare with radiology, to compare with, or to see how therapy affected the disease and the body. So all of these issues would be raised, and obviously even for research, because research indirectly will help quality and healthcare. Additionally, we should pass on this information to our medical students, to our non-pathology residents, and to our colleagues in healthcare, in nursing, other physicians in the ICU, in the community, in family medicine, and also to our colleagues in public health and vital statistics. Another issue is to raise this awareness with the public, educate the public about the and receive information from the public about their restrictions regarding traditions or cultures regarding death, and how we can overcome these fears that they may have, either by limiting the scope or the incisions, or if the issue is not the invasiveness, however, the issue is time, by trying to meet the demands of time. Another issue would be to limit to the examination to not affect specific types of organs, is another issue that is raised frequently by the public. Another way to help the public cooperate with the autopsy would be to use either employment of in public relations social workers, or individuals that have social work training. Many places have performed this and labeled as Office of Decedent Affairs, and they deal with the issues, whether legal or other, and they're sort of a hub for the public and for the healthcare workers, for the physicians ordering the autopsy, or the nurses ordering the autopsies, and the pathologists performing the autopsies, and therefore they link everyone and are able to navigate the requirements that are needed by the family or next of kin. And the last that I would like to explain is what is the future, what are future directions. We are already performing, as I said, specialization of pathology in the North Zone. It's already in effect long ago in the South Zone. And additionally, we are at AHS, we are digitalizing the request of the autopsy, which to my understanding, and much of the recent literature shows that digitalization of these requests makes it easier to use and easier to order. And then the next question would be the use of AI as with regard which autopsies will be higher yield or lesser yield, and using AI to help us navigate which cases we should order or not is also something that many people are talking about, especially with other specialties. So they may be in the future. So I think that these are some of the solutions, but I would be honored and enjoy to hear solutions from your side with regard to the postmortem examination and what is a proposed solution and how we can work together. And then lastly, I think we should own the term deadmitten, because we should be the ones that speak for the dead and be called, and we should be proud of being called deadmitten, because we speak for the dead from a moral point, a scientific point, and for the benefit of the future of health of the all Albertans, similar to this haunted house that adopted this name, and to my understanding is very successful. Some frequently asked questions about the autopsy. So first is the cost. There is no additional direct payment required for any of the procedures performed by AHS. There is, however, to my understanding, depending on the funeral home, if they transfer the body from AHS to the funeral home, it may cost differently if it is within Edmonton or it is in a further city. The legal issues, so it does help closure with the family, and therefore it decreases litigation for the or for healthcare. Funerals can still be open casket. There is usually no visible incisions, and therefore the funeral homes do a really good job by preparing an open casket without any issues. There is definitely flexibility available with any cultural issues regarding the extent of the incisions or the speed. If we are able, we can overcome them if we understand what the limitations are by the family or next of kin. The autopsy, as I've explained, can be limited or complete, depending on preference. However, as pathologists, we always prefer the complete because it gives us more answers and we can link the different diseases and the organs and the diagnoses. The autopsy does not form extra work for us. We are specialized here in autopsy and we enjoy performing autopsy. Additionally, our neuropathology or brain and nerve pathology is performed by specialized neuropathologists that also enjoy the work of autopsy. As I explained before, research and teaching are a way that the community can pitch in with us to improve healthcare in Alberta, and so we are able to involve the community with healthcare to perform any research projects or teaching of our medical students. And then last but not least is the speed. We usually have the preliminary diagnosis out within the 72-hour time frame, and usually it is much less than that. The same with the final diagnosis, because the processing of the tissue takes time in addition to ordering some other tests and analysis. Will take time. It's usually within a month, but many times it is within 60 days, depending on the complexity of the case and any consultation requests from specialized pathologists. In the end, I'd like to leave everyone with a message, why not speak on behalf of the dead and own the term deadmitten? I'd like to thank you in all the languages that Google knows, and I'll leave the mic for Michael. Thank you.